Welcome to the Bariatric Mindset Podcast. I'm your host, Dr. Kristen Lloyd, mindset mentor, somatic coach, and transformational guide for those on the path to true healing. Whether you've had weight loss surgery or on GLP-1, simply seeking a new way forward with food and your body, this space is for you. This podcast is a mission to change the narrative, unlearning the patterns that no longer serve you, moving beyond quick fixes into deep, embodied healing, lasting mindset shifts, and true self-leadership. We are healing from the roots, rewiring the mind, regulating the body, and returning home to ourselves. We are here for growth rooted in honesty and self-trust, because that, my friends, is the foundation of healing. So grab your cup of joe or your H2O and let's go. All right, everybody. Welcome back to the Bariatric Mindset Podcast. I am your host, Dr. Kristen Lloyd, and I have a very special guest today. And I'm very excited because this is actually my first guest that's not a member of my team. So I'd like to welcome Dr. Eric Smith, who is a board-certified general and bariatric surgeon who has been in practice since 2006. And with the Kentucky Bariatric Institute, he's also the medical director of bariatrics and robotics for all of LifePoint Health, a nationally recognized health system. Thank you, Dr. Eric, for being with us today, because I know we are going to talk about some really juicy stuff today that people want to know about. This is going to be edgy because there is a lot of conflicting information in the bariatric world and obesity medicine. What do I do? What should I choose? Where am I going? There's so many options. And I saw a post that you made and I reached out immediately. That's how we reconnected. I'm so grateful that you said yes and that we're here and let's do this.
Yeah, I've had a few of those lately. They're apparently hit some buttons, so that's good.
In a good way.
You know what? It creates discussion. That's what we're here for.
Yeah, that's what we're here for. And being that I'm a patient and over here on the psych side, I may see a totally different, I don't know, maybe we see similar things, but that's why I wanted to have you on is what are you seeing with the changes in bariatrics with the advent of GLP-1 medications, and how has that changed the patient landscape and patients' insights about bariatric surgery? And what do we know other than what's out there in the media about GLP-1s?
Yeah, that's a loaded question we might have.
I know.
I get where you're going. It's been if anybody out there thinks me as a surgeon thinks it's not a great thing, they're missing the boat and they're missing the point. And if they've met surgeons who think it's not a great thing, because I can tell you my peers who are typically very high volume, very well-respected bariatric surgeons, they think it's a great thing. If the surgeon says it's not a great thing, there's a problem behind that. Because first and foremost, there's two really positives that have come. Number one, when you get big pharma money involved, they're going to get their point across. Mm-hmm. And I'll be really honest with you. What they have done is they have finally raised awareness at an all-time level that obesity is a disease that we deal with and that it's a true problem.
Yep.
And we've started to finally move the needle that it's not a self-inflicted problem, that it shouldn't be filled about guilt and shame and blame, that it's a true health problem. Now, and then we can veer off in any direction where it comes to our food system, which I'm sure we'll talk about. What's the underlying causes? Is it multifactorial? But their dollars, in this case, worked to the advantage, because when Oprah talks on TV about weight loss and GLP-1s, and when other people do that, people are starting to listen. And our surgical societies, I don't want to say that we've failed. It's not for a lack of trying, but let's be honest, we didn't have the financial power behind it. People were scared of surgery when they probably shouldn't have been, because it's extremely effective and safe, and we'll talk about that. But we weren't moving that. Yeah. And so that is the one part I will thank Big Pharma. I have a lot of disagreements with them about a variety of things. Right. That right there was a huge positive, because you're right. It is a hot topic, and it's a hot topic because people are talking about it. So if there are people who are talking about it, that's a good thing, because it means awareness has been raised. And then I think the other reason is it's given us another option. It's given us another option on how to treat a complex problem. So having multiple surgeries at our disposal gives us a better chance of getting better care for patients. And now we have a medication option. And so ignoring whether it's the right choice for everybody or a small group of people or a large group of people, it now lets people say, you know what, I'm now aware that I didn't do this all to myself. I want some help. And now I have options that are surgical and medical. Where do I start?
What do you think? There are a lot of different options, right? And I know what GLP-1s do in the gut. So I'm not asking for the science, but do you think is the key difference that makes this drug stand out? Or so is it just the gut-brain axis? Because there are other things that have impacted the gut-brain axis. And again, I said I'm not necessarily going into the weeds there, but what makes this so different that people have compared it to effectiveness to weight loss surgery, to bariatric surgery? And we know still that the data shows bariatric surgery is much more effective. But
because up to this point, the best medicines that we had on the market ignore the side effects, and a lot of them popped up, then they had side effects, then they went away. But the best medicines that were out there were achieving a very small percentage of weight loss. Let's just be honest. Either people that lost weight on the oral pills, even when we started realizing some of the antidepressants had a weight loss impact, things like that, we were talking like 2 to 5% total body weight or total weight loss. And that's not a lot, because most people, if they're trying to lose weight for the right reasons, this isn't the person trying to lose 15, 20 pounds. And that's a whole nother talk show. Because unfortunately, these meds are being given to people like that.
Right.
But for people who truly need to lose weight, 5% is not enough. I always tell people, yes, I can make you lose weight, but my job is to try to make you non-obese. There's a difference there, because if I make you non-obese, I flatten your mortality curve. Right. If someone's morbidly obese, they have a chance, and I know we now have classes of obesity, but for just conversational reasons, if someone meets that category, their risk of dying is elevated and their lifespan is shortened from 5 to 20 years. So I want to make someone non-obese and take away that risk, or neutralize that risk and take away those medical problems. So those meds never really offered a real dent. So when these medications came out and we saw the preliminary data that was starting to achieve double-digit total weight loss, it really raised some eyebrows. And people thought, okay, I want some of this. Let's be honest. Hollywood helped the exposure.
Yeah.
People on TV, people in the movies, really rich families that have TV shows, they were losing weight and it was noticeable. And so people started trying to figure out, what is this? What is going on? I want some of that. And so that's really what first moved the needle. We can talk about all the studies and all the data, but that's really what raised awareness and drew the attention of people.
How do you think GLP-1s compare with bariatric surgery when it comes to long-term weight maintenance and metabolic?
Yeah. And that's a great point that you said that, because I tell patients, today was my clinic day, I always tell patients, weight loss is easy. Weight loss maintenance is really hard.
Yep.
But unfortunately, it's not sexy. Because if I take a picture 6 months after surgery and I hold up a pair of pants and I say, look how much weight I lost in 6 months, that's exciting, that's sexy. But if I say, look at me in 3 years, I look just like I did at 2 years. And me as a surgeon, I'm like, man, good for you. That's amazing. But that doesn't catch people's attention. They're like, that's what should happen. You had surgery. You took the easy way out anyway. It's really important that you bring that up.
Yeah.
We can't talk about the longevity because we don't have it on the meds. And that's not a knock against them. That's just real talk. We have 2-year data best. We're starting to get some 2.5-year data out there, but we have 2-year data. And so if all we can do is compare 2 years to 2 years, they don't compare. I shouldn't say that. That's not fair. They're significantly less in their weight loss outcomes than surgery. They're still real. But when you compare the lowest weight loss performing procedure, lap band, which has really died and gone away, they are reasonably close. Only best case scenario, are they reasonably close? Bypass, say, big gap. Big. Right. In fact, when we talk about total weight loss, but we also talk about excess weight loss. That's really the numbers that we look at.
Right.
You're talking about, we do surgeries now that can be double what the average Joe or Jane, because the part that bothers me about the GLP-1 is they love to talk about up to, and that's like me taking my rockstar patient and running an ad and not putting in the fine print, results may not be expected, and making people think this is what everybody does. That is not true. These are not averages they're talking about.
Yeah.
Again, it's not a knock against the GLP-1, but right now we do not have any reason to believe that we're anywhere close that this can mimic what we can do with surgery. And that doesn't even get into the level of long-term compliance that's required that I think we'll talk about.
Yeah.
I think the sustainability of weight loss, when we talk about surgery versus meds, we have to think about this. If you do surgery on me, you can't take it away from me unless I let you. So my compliance of the primary modality that helped me lose weight, surgery. Now, we all know it takes lifestyle changes, but the primary thing that helped me lose weight, surgery, is permanent. It cannot go away. If my insurance changes, they can't take it back. Doesn't reverse. Believe it or not, most surgeries don't stretch and dilate like people talk about in this day and age, the way that we do them. So my level of compliance has less of an impact on my results with surgery as opposed to medicines, because now my level of compliance can be involved in, do I feel like taking it every day or every week? Do I feel like paying for it every week? Do I feel like maybe I want to skip this week because I'm really nauseous and I don't want to do that? I want to change jobs. My job went from insurance that covers it to now it doesn't. See, compliance now is ebbing and flowing because those medicines have to be taken forever to maintain those results. Even the obesity medicine specialists will admit that. Everybody should admit that. But my compliance now impacts that.
Yeah.
In surgery, my compliance is only impacting, do I show up for my follow-up visits? Do I choose to eat the way that I've been educated? And am I compliant with things like protein intake and exercise and taking my vitamins? GLP-1 patients, their compliance impacts those exact same things because those things have to happen in addition to, do I choose to choose my tool every day for the rest of my life? And not enough people were talking about that.
Yeah. And I just launched a course called Beyond the Injection. And what I put in there is the basics are still the basics. The basics are still the basics. You may not have had surgery, yet you are still subject to the bariatric basics, which protein, movement, water, that's management. And your supplements, your supplementation may be different, right? But they're going to be different if you have a sleeve or a gastric bypass, or if you have a DS procedure or any other of the gastric bariatric surgery.
Yeah.
They're going to be different. So you're still going to need some level of supplementation. It just may not be the same dependent on the absorption.
It's what we tell our patients if they're a medical weight loss patient on a GLP-1. Your regimen that you should follow is at minimum the exact same regimen as a sleeve patient. Because the sleeve, I don't impact absorption.
Yeah.
Right?
Yeah.
Now, I impact some hormones like ghrelin. I still see GLP-1 hormone manipulation. We should talk about that too. But as far as absorption of your nutrition, I'm only impacting it because I'm decreasing your intake. And that's what a GLP-1 does.
Wow. Yes. Yeah.
So I tell people, don't look at a sleeve and say, all my sleeve patients are recommended to be on a bariatric, not just a Walmart. I shouldn't say Walmart, but not just the basic over-the-counter, a bariatric multivitamin, which can still be very affordable. We can give patients good bariatric vitamins for less than $1 a day.
Yeah.
But they should be on a multivitamin with iron, unless there's reasons they can't take iron, and they should be on calcium supplementation at a bare minimum if they're asleep. GLP-1 patients should be on that too. But unfortunately, the majority of people are not, and they're not told that they should be. And I have a patient I know has a thiamine deficiency who is my age, who's in a wheelchair right now because she was taking a GLP-1 and she started developing symptoms and even got online and looked it up and asked her doctor, and her doctor says, you're not a drinker, so you can't have thiamine deficiency. I've reviewed cases of sleeve patients who develop thiamine deficiencies, which we see that more in the malabsorptive procedures, but anybody who's nauseous, having some vomiting, and having very poor nutritional intake can develop vitamin deficiencies, including thiamine. And I hope and pray anybody who listens to this who's taking a GLP-1 has a physician who has put them on a good multivitamin regimen and is checking their labs just like I would check a sleep patient.
And what I would say about piggyback to that is the other thing that I have seen, I see primarily bariatric patients who are struggling clearly with the emotional side or still struggling with food. Some of them are on GLP-1. And we talk about the different types of food noise. That's not what I'm going to go into. But what I've talked to them about is I've had people say, gosh, look at my arms. I have so much hanging skin. And I will say, are you doing any strength training? No. And I'm like, what? So that's the first thing is I'm going over the definition of sarcopenia, which, hello, everybody. I'm going to put it in the show notes, but sarcopenia is like the lay term is skinny fat, where you have more fat mass than you do lean
muscle mass.
Muscle mass. And it's actually a detriment to longevity, to health, to you're at higher risk of osteopenia, osteoporosis, and a lot of other things, especially as you age, you're higher risk. As we get older, you can fall, hip fractures, like all of that. So I'm doing a lot of education, not a trainer, not a dietitian, but I'm doing a lot of training on that. And I think that is a very important thing. And why I bring that up isn't to go off on a tangent about that, but just to talk about how there's very little education that a lot of these folks are getting, because they may be already working on some of this stuff, but let's say their A1C goes up, or they are battling with some of this intense food noise. Great. Again, this is why the medication is good to help them while they're working on implementing the lifestyle changes. What is missing, though, is that there are many practitioners, and these folks are all over the country. So I don't know who's prescribing, if it's a PCP. So this is not about blame. It's about education and bringing awareness that we need to know this stuff, because I've seen and I work with primarily women, and it's, I didn't know that. I didn't know. My doctor didn't tell me I needed to be strength training. I didn't realize. And so I wanted to know what your take is on that, because I think that's so important.
Absolutely. Here's what I would say first to all that. I tell patients every week, you have to be your number one advocate. I hope you have support system at home. Our practice will provide a support system for you. I hope you have family members who are supporting you along this journey. But regardless of that, you have to be your number one advocate, because you're the only one that you can guarantee won't fail you.
Right.
We're all humans. As your physician, I may fail you, not intentionally, but you may call or need me and I forget to return your call. I failed you. Right? But if you are your number one advocate, what that means is, in that case, what I'm trying to get them to say is, if you need more information, speak up. Tell me I need help. Even if I've taught you something 20 times, if it didn't resonate with you, make me tell you 21. But in this case, patients have to be their own advocate. We can't go try to hunt down the bad players who are prescribing. We have to educate the public, and they have to demand for themselves what they know they should be getting with these medications for follow-up and support. And so, the bigger picture, you're exactly right. I'm worried that in the next 10 to 15 years, we're going to have a lot of frail elderly people walking around that are going to bring a whole gamut of other issues. Again, that's not the GLP-1's fault. That's the mismanagement of these medications, because anybody who has a license to write a prescription now can write them. But yeah, bariatric surgery didn't work that way. Here's what I would say about sarcopenia and why it's so important to stress that. We have to stop talking about weight loss and have to start talking about fat loss.
And body composition. Amen.
And if anything, the reason is, I use this as a great example. If I have a 250-pound woman who's 5'4", and she has bariatric surgery, and in the first 6 months, guess what? She's going to lose 50 pounds at least without trying, for the first 6 months. But if she's doing it without trying, that means she's not taking her protein in, she's not taking her vitamins, she's probably not strength training. She's probably eating the same food she always ate, which isn't nutrient dense, eating less of it, losing weight. What is happening? At that time when she was 250 pounds, if I did a body composition analysis on her BMR, or the number of calories that required to keep her at 250 at that body composition, was probably around 1,300 calories. Let's fast forward a year and a half. She's lost weight without trying. Now she's 150 pounds. Her new calorie number is probably 850. It's physically impossible for her to maintain that new weight, because you can't expect anybody to eat 850 calories a day. You can't. We don't want you to. The difference is, if she maintains her muscle mass and loses the same amount of weight, but it's 80 to 90% body fat. Her calorie number after that 100-pound weight loss is still 1,300 calories. I've seen patients lose over 200 pounds and their calorie number actually go up because they maintain their muscle mass. So more importantly, what I'm worried about is we're fictitiously rewarding weight loss when it's half muscle mass, 40% muscle mass, even 30% muscle mass. What we don't realize is we've dropped their calorie requirement so low, it's impossible to maintain that. So now what's going to happen? I'm going to regain weight. With surgery, what happens? My surgery failed. Revise me. Now what happens? Because we're always going to point at the thing that caused the weight loss and fix it. But now we have a medicine, so let's just up your dose. We'll just keep increasing your dose. And as you increase the dose without teaching them the fundamentals of how to lose weight the right way and how to only lose body fat, what's going to happen? They're just going to lose more muscle mass and body fat. And they're going to drop that calorie number even lower. It's a vicious cycle. We've seen it in weight loss. We warn against it. I'll be honest with you. That's why we don't celebrate when people lose 100 pounds in our office. It's not to be critical of the practices that do. I get the excitement about it, but I want to know more. I've seen people only lose 60 pounds, but 50 of that was body fat. I'll take that all day, every day over the person that loses 100, but 50% of that was muscle mass because they are trending in a bad direction for weight regain and then wanting more intervention. And now that meds are accessible, let's just increase your dose. Here's the other thing nobody's talking about. We know when it comes to pharmacology that anytime you, and I'm not a scientist any more than a surgeon can be, and I'm not a pharmacologist, but anytime you talk about receptor manipulation, meaning block a receptor or I stimulate a receptor, our body responds. Meaning, if I block, say, a beta blocker for my blood pressure, if I'm blocking the beta receptor, we know in data and studies that our body tries to override that. And what does it do? All my receptors are blocked. I'm going to make more receptors. I don't like it. It's unnatural. When you stimulate a receptor, your body does the opposite. It has a tendency to down-regulate receptor. Oh, I'm being stimulated like crazy. Maybe I should have less little points of stimulation. I can't tell you that's for sure going to happen, but we know that happens in other drugs. So does that mean that 5 years from now, the person who's taken this dose of Zepbound is now not as sensitive to it and needs 3 times the dose? But 3 times the dose brings 3 times the side effects. You get where I'm going with that?
I do.
And these are all questions that we have to ask because, again, if we're accepting the data for meds, we are signing up for I'm on this for the rest of my life.
And that is why I wanted to have this discussion. But one of the things that I don't see people talking about enough, one of the things that you brought up is fat loss. I work with people all the time that will say, the scale is stuck. Throw out the scale. Are you doing a DEXA? Are you doing a bod plot? What are you doing that is measuring your body composition? Let's look at that because the scale is going to show you water weight. It's going to show you changes in your menstrual cycle. It's going to show you other things. It's not a really good measurement. And yes, we've used the BMI and BMI is still used.
Yeah, but it's flawed. It's flawed too.
Yeah. And one of the things that I harp on is the lifestyle change and also working on the root causes. But the other thing that I wanted to talk about, do you think that some of these medical tools, or let me step back, what would you want patients considering GLP-1s to understand before starting medication? We've already talked about some of them, but
yeah, big picture. First questions that we say to a patient if they're interested in medical weight loss is, number one, are you willing to commit to this medication for the rest of your life? It may change. We may have a monthly dose down the road. I think we will years down the road in the near future, maybe.
Right.
But are you going to take a medication for the rest of your life? Number one, because if you're not, do not start it. And once you're on it, you start it. Right. Number two, do you feel comfortable financially supporting this medication for the rest of your life? Whether it's your copay currently or if you have to pay for it yourself. When the compounding pharmacies were finally stopped, when the shortage was over, and Lilly Direct came out, and then the Ozempics of the world, they came out with their version of that too. But when the direct-to-consumer programs came out, they got rid of the pens, they created the vials. Those are great. But here's the deal. We now know they've drawn a line in the sand. When you're a pharmacology company and you have a drug that's so hot like what they've got, you are going to ride that patent until the very end. You should. You're protected for that patent 17 years or some time spent in the trials and everything. But let's say they've got 10 years left on their patent. If you've got a patent, why would you not want to take advantage of it? That's why you invest millions and millions of dollars in the clinical trials to get the drug on the market. Their bottom line is now basically $500. Yeah, you can get $350 for the intro dose. No, hardly anybody stays on that intro dose. So just accept the fact when you get to the top dose, it's about $500 a month. Now, that's much better than $1,000. I always ask the patient, though, is that reasonable? Because if you come to me and say you can have a $1 million Ferrari for half price, I still don't want to pay $500,000 for it. I'd love to have it, but that's still above what I want to spend on a car. So are you willing to pay that for the rest of your life? And then third, if you do have insurance, are you willing to accept the fact that your job, your insurance coverage for your employer could change, or you may change jobs? Because if your insurance pays for surgery and your job changes, they don't come take your surgery. But if your insurance pays for meds, and we have seen over the past 2 years, major corporations who once covered the drugs drop coverage because they physically say, this doesn't make the math ain't math. I've got people paying a $350 premium a month. I'm giving them $1,000 drug a month. We are going in debt. So I'm not defending it. I'm not supporting it, but it's reality. Those are the three questions I want patients to know. If they're comfortable with that to start, then what type of support do you have in place?
Yeah.
Are you willing to commit to the same lifestyle changes that we want you to commit to with bariatric surgery? There's such a misconception that bariatric surgery patients have to eat different. You can eat anything you want after bariatric surgery. You can drink with a straw if you want to. You can drink carbonation. Believe it or not, whether some surgeons may prefer it or not prefer it, there is nothing off the table. What we want you to do is eat healthy. There's that first 6 weeks, there's certain things that you work through and escalate. You're not giving up certain foods. We're asking you to give up certain foods for your health. And so that's really no different than the meds. And so we need to be asking these patients the same question. So I would warn a patient, if they're listening to this, if they have not had a provider go through this with them, it's a red flag.
Yeah. What's really interesting is when I went in for my surgery, I didn't realize this until I met my surgeon the day before surgery. And he told me that he was also a sleeve patient. And I was like, wow, okay. I remember because it was October, and at the time I was obsessed with pumpkin spice lattes. And I said, I know I can't have it now, but am I ever going to be able to have one again? And he said to me, you will be able to have anything. But if I can impart any knowledge to you, I want you to think about this. He said the same thing about the first 6 weeks, but he said, at some point, you will get to a point that you will be able to, and he was talking about grazing, get up to 3,000 calories a day.
And it's not because it's stretched.
It's not because it's stretched. And he said, because of the small meals and all of that. And he said, so I want you to be conscious. That could happen, and you need to be conscious about what you're eating. Can you have anything? Yes. Do you choose? Do you want to have everything? And that's up to you. And so it's basically the same kind of thing that you're saying is we're trying to support you having this healthy lifestyle, but nothing's off limits. And fast forward to, 5, 6 years ago, looking at 50 grams of sugar, I haven't had a pumpkin spice and it's my choice. It's mine. Should I have it? Yeah. Do I want to? No, because I don't want to put that in my body, but that's
and those conversations. And again, I'm not saying there's not people who are prescribing these medications that aren't having these conversations. But I am saying, and you know what? There's some bariatric surgeons who may not be having these conversations. But by and large, most high-volume, reputable bariatric programs, they are having these conversations with their meds and with their surgeries. These conversations aren't happening a lot with a lot of people who are getting the meds.
Yeah.
When you're seeing a provider that's expecting to see 50, 60 people a day to make a living, there's not a lot of time for that. If they don't have dietitians on staff, if they don't have these things. So am I saying that you should never take the meds from that doctor? I'm not necessarily saying that, but where are you getting those other resources from? Where are you getting that other education from?
Yeah.
Again, be your own advocate. Are you using an online service? Are they doing head work with you? Are they doing whatever that may be? Some of these online groups that they can join for a monthly fee. That's where I want patients to understand. If we even want to go there and say we finally have meds that are at least in the same conversation as surgery, then why would we be so foolish to think that they don't require the same modalities of support and education as surgery? Because nothing in life works that way. You don't get really good results for nothing. Everything that's worth something is hard and it takes effort.
Absolutely. And it was interesting because last week I was talking with a trainer and it was very matter of fact. He said, Kristen, nobody gets fit on accident. And it was just like, ding, and that is gold. And it's because it's so important for us to realize it does take intention. It does take intention. And a lot of times when I see folks, they're like, I had surgery. And yeah, but have you dealt with your childhood stuff? Have you dealt with your trauma? Have you dealt with the emotional eating? Have you dealt with the reasons why you're eating, the deeper behavioral patterns that, I tell people there's nothing wrong with having desire. Desire is part of who we are, right? When it becomes like my precious, the thing that it make one dictionary. What are the things? But this is where, what do you see in terms of the future of obesity treatment and even combining the meds? Do you see that I know this may be 2-in-1 question, that there are certain people who do better with both, and yet are there some people that, because it's not an either or, we know that. I work with people who are on a GLP-1 post-bariatric. And so I'm curious what you are seeing with the patients and what may be coming up in terms of how that's evolving.
Yeah, I think it's playing a role in all of those categories, to be honest with you. We're seeing some people come in, and 5 years ago, I probably would have seen them a year ago. Meaning they tried the meds, but so they didn't come to me when they were ready to address their obesity because they saw someone else for the meds. That's fine. And they came to me and said, look, I lost 100 pounds on the meds. I was miserable. I hated the way I felt. I vomited all the time. Anytime I felt like my weight loss stopped, they increased the dose. I was miserable. I just said, I can't do this. I tried to go off of them. Look where I'm at now. I need a more definitive treatment. That's okay. That was part of their path. That was part of their journey. We're seeing patients after surgery that are struggling. Now we have that option to add them in. I think we have to be very careful now that we have that option that we don't add them too soon, because it's really easy. I've got that med over there. Have we really dove deep? Have we done the head work that's necessary? Have we really looked at the lifestyle changes that they have or haven't made? Are we looking at body composition? Are we actually letting them set themselves up for failure? Because even with just weight loss surgery, they lost too much weight loss. So they are eating less, but they're not seeing the weight loss continue because they ate less at the beginning without getting protein. They dropped their calorie number down so low that they're like, man, I'm eating so much less than I did before I started having surgery, but my weight loss has already stopped because their metabolism is tanked because they have sarcopenia.
Right. We
are seeing those people that are 2 and 3 years out, that maybe they're 50 pounds away from where they want to be, and they can introduce a med. We believe that some of these post-op patients almost may be super responders to the GLP-1s. Bariatric surgery, there's not enough being talked about it, but bariatric surgery increases GLP-1 levels, increases PYY levels. PYY is another hormone very similar to GLP-1. It decreases ghrelin levels. It improves our sensitivity to leptin. We could go on about all the hormonal stuff, but let's just talk about GLP-1. So if we know statistically, chemically, massive spikes after bariatric surgery, that lasts a long time. Their GLP-1 levels natural go up, and then we throw more in, we're really pounding those receptors. So maybe at a lower dose, post-bariatric patients may be a super responder. Maybe that's a good thing. Maybe we find that those patients are very low dose, less frequent dose. It's something that we have to entertain. It's something that we have to consider. I warn our team to not be so quick. And we have to be careful because we are the people who are defending the obese population. We're the ones that are wanting to stand up for them.
Yeah.
And we don't want to say, do it the old-fashioned way. We've been telling you for years that doesn't work. But when I have a patient who's 6-9 months out and they're like, I'm not happy with my weight loss, is it time to start the med? Let's dig real deep, because man, once you open that Pandora's box on the med, you've married it. And I think we need to be careful with that.
Yeah.
Because the med isn't going to fix the lifestyle changes. It's really important we address those food choices. I think we need to be preaching to these people that they have to base their diet on a whole food diet.
And that is something that I talk about quite frequently in my practice. And the other things, because food, let's talk about food. Let's talk about food, because highly palatable foods. I saw a report. This was not in the questions that I sent you, but I saw something that came out a couple weeks ago that the food industry is now trying to change how they're producing things to combat GLP-1s. This is very generic, not a single company. a little scary because it's like, seriously? Really? And because we've seen that there are quite a few companies, not naming any names, but they're big ones, that they've seen a reduction in snack
Sales.
and sales.
Yeah.
So I'm curious because I also see where there is this fight with the people that I work with. I primarily work with, I see folks that have a lot more deeply rooted stuff. I don't talk to the folks that are just, well, I do, but they're not.
They're just dealing with cravings.
They're not just dealing with cravings. Like I am dealing with deeply rooted, like trauma history, been overweight since 3, got put on diet pills at 5, all of the really intense stuff where publicly shamed, got fruit in your Easter basket and in front of all the other kids that got candy. Like my group is not they're not going to go to an average support group meeting and get what they need because they're going to walk away going, yeah, I don't know how to deal with all this stuff. So we may be talking apples and oranges. The food is still the food, and the attraction, the connection is more than just dopamine, which can be exciting and stimulating. Like you were talking about, what's sexy versus not sexy. And I'll tell them, nobody's marketing broccoli, right? You don't have, people are marketing broccoli.
And there's not a single entity that can benefit from it. So I think we have to stop and think about that first. I'm going to use an example that sounds off topic, but it's very similar.
Yeah.
If you're waiting for certain supplements to have clinical data to show how beneficial they are, wait all you want to, but don't hold your breath because you're going to turn purple pretty quickly. Because there's not a single entity such as a pharmaceutical company that can benefit. If something like magnesium could truly be life-changing, you're just going to have to accept the small subsets of data that we have, trust that, and try it and see how it impacts you individually, because there's no one that's going to invest the hundreds of millions of dollars like they will for a GLP-1 to get it on the market and get an indication. And if it gets an indication, not one single entity benefits from that. Right. So food is the same, right? But like an Oreo is a single entity, for example. The food plot has been played out. Big Food was bought by Big Tobacco many years ago. The same scientists and chemists that worked for Big Tobacco came over. They work for Big Food. Big Food now is no longer owned by Big Tobacco, but their chemists stay.
Yep.
And they don't call it addictive. They create products that are termed hyper-powered. It's very intentional. There are whistleblowers that have admitted this. It's very clear. Their job is to not just put an artificial sweetener in a product just enough to make it seem like sugar. Their job is to put an artificial sweetener in a product at a level that creates a response based on MRI scans and everything else that gives you that sensation, but you need more. And so I think the most unfortunate thing about our food system is it is preying on the very people that we're talking about. Because what sells front of label packaging? And what's on front of label packaging? Terms like low cal, no fat, low fat, sugar-free, all these terms that are very loose.
High protein.
High protein. There's a drink in our hospital that says 35 grams of protein on it. And on the back, by the way, there's 65 grams of sugar in it, and it's all high fructose. But they can put whatever they want on the front. So I can go and get a drink, and I can put 3 different types of, I'll be generic, syrups in it. You can call them overweight syrups or underweight syrups, or I won't use certain names. Pick on somebody. But I can flavor it however I can feel really good about it because none of that has calories in it. I'm not at the Starbucks getting a frappe that's 350 calories. And I'm doing that because I think, man, I'm finally found options that are reducing my calorie intake. All along, I'm creating the noisiest brain that I've ever had.
Yep.
And now we want to call it food noise.
Yes.
I didn't get noise from food. I got noise from a chemically engineered substance. There wasn't a nutritional thing in that. And so, but what happens is these people are choosing foods that they think are low calorie. They're also low nutrient dense. And it's perpetuating the problem. So when someone says, that's ridiculous, you don't have to give up your Diet Coke. Your Diet Coke can't make you gain weight. You're right. Directly, it can't. But I believe there's a lot of people that have to give it up because that Diet Coke is leading to other things you're eating throughout the day, and the consequences of it, you can't handle it. That's why some people can have a drink and not have a problem. Some people can't have a drink without there being a problem. And we've got to stop treating food like people.
Yes.
Meaning we should accept it all.
Yeah.
There is bad food, and there's some things that we have to stop calling it food. And so I think when we eat whole foods, like I told someone the other day who says, my thing's chocolate. I'm just addicted to chocolate, and I'm really struggling with it. And they even said, I need to do some homework on chocolate. And I said, I think that's great that you're admitting that, but here's what I want to tell you. You're actually not addicted to chocolate. I said, what is chocolate? I love it. She started naming brands and types of chocolate. I said, no, that's chocolate. Yes, it is. I said, no, it's not. 95% of the chocolate sold in the United States does not meet the definition of chocolate. Chocolate is cocoa beans and cocoa and some of the butter and the oils that can come from that. And then you find a true, whether it be cane sugar or true sugar, to slightly sweeten it. You're eating something that has soy, it has milk products, it has all these other chemicals, it has other sweeteners in it. You're craving the crap that they're putting in a product that you think is called chocolate. And until we educate people about this, we're never going to get ahead of it. And we have to stop saying everything's okay in moderation. Don't think it is.
And I think the other part of that, though, is what is moderation? And one of the things that I tell my folks is I would tell myself that lie before surgery is I'm having pizza in moderation. I have it 4 days a week.
But maybe it was less than what you had before. And so in your mind, you're like, this is within moderation.
But it was a straight up lie. And
right.
When we're looking at what is moderation, it might have been one time a day at different, it was lunch here and there, leftovers.
Yeah.
Where are we honest? And the other part is, I will say, is this a food or is this a food product? So food product is something that I think is labeled as a food, but it's not.
Yeah.
Nutritionally sourced.
We had some fun on a social media post, and we played around with ChatGPT. By no means am I saying ChatGPT is 100% accurate by any means, but we played around with it, and we asked ChatGPT some questions. We talked about what is food, what is ultra processed food, and basically we came to a conclusion that I already had felt like I'd come to.
Yeah,
is a lot of these foods are not food; they're chemically engineered edible substance.
Yeah,
if I go out and I pick up a dandelion out of my yard and I eat it, does that make it food? If I go get a piece of trash out of the trash can and I eat it, does that make it food? Now, I think we have to stop and ask our question, what is the primary role? The primary role of food should be to supply nutrition to our bodies, energy, nutrition, macronutrients. If we start looking at a product that is not its primary goal, or the majority or even all of the contents in it aren't providing that goal or that purpose, why would we call it food? There's a lot of things that I can eat. I could chew on this pillow I'm leaning against right now. I could probably swallow it. I might get an obstruction. I might pass it. Does that make it food? There are so many foods. Look at a cheetah. There's not a single nutritional, valuable product in that substance. So why do we call it food just because we eat it? And that's why I think we have to be careful when we just call this stuff. Then is it food noise or is it chemical noise? I have a problem when we give the medication for food noise only, without addressing the root of the problem as to why the noise exists. Because if you came to me and said, I got a problem with cocaine, but is there a way I can do it 1 day a week and give me a medicine so I don't do it 5? I've got a problem with it. I would say, but the root of the problem is the substance. Let's find a way to address the substance. Let's do some serious therapy. Let's do some group work. Let's some behavioral analysis. Let's look at all sorts of factors. Let's remove you from environments that perpetuate the problem, and let's get rid of the problem.
Yeah. And so a couple things. One, I noticed, because a lot of those things, Oreos, Cheetos, I ate a lot of pre-surgery. And one of the things that I noticed was my taste buds changed once. I'm going to use the word detox, but that's a loaded word for some people. They just stopped.
You stopped it.
I stopped. And it was after my cheeseburger in a blender, my post-op staff said you can have pet in one of the phases. And I in a blender and that one spoonful, and my husband's, yep, it's working, because I was doubled over in pain. And I was like, wow, Kristen, you have a problem with food, as if me having weight loss surgery wasn't enough of it. Hello. And So for me, it was using food as a coping mechanism. It was all of the things that I had never addressed as a therapist, as someone who was...
You're human. We're all human.
Right. And realizing, whoa. And I bring that up because to your point about food noise, when you change your taste buds, right? Because people will have spinach or mushrooms or whatever, broccoli. Ooh, I don't like that. Have you had it after quitting or not having some of that food after a while? Because it will, or a lot of the chemically induced foods. The other part is a lot of the things that you're talking about, the food noise, and I'm giving a talk later this year about food noise and the different types of food noise. And one of the things as I was doing some of my research and in the work that I do, I work with a lot of people who, when they've gone through surgery, whether they're on a GLP-1 or not, they're having to deal with, I'm not in a good marriage. I hate my job. I'm about to retire. Losing a parent, being a caregiver, like I could go on. And those things are driving them to seek pleasure in food.
We know, we're very aware in the bariatric surgery world about transfer addictions.
Yep.
We're very aware of that. We educate patients on that. We warn patients who've had addictions in the past or addictive behaviors. Listen, I've done this for 19 years. I've seen people go from being alcoholics to sex addicts. I've seen people who maybe were sex addicts and turn into alcoholics. But I've seen a lot of people, and I'm not saying everybody who's obese has a food addiction, but I've seen people who end up turning into, whether it be sex, drugs, alcohol, fitness. I've seen people go off the rails with fitness, almost to the point that it's so extreme it's not healthy, because they didn't get to the root of the problem that I need something to reward myself. I have to fulfill that dopamine response. That's a head change. That's a perspective change. That's finding joy in the basics and the simple things and the healthy things. But we're required as excellence, as misquit certified centers, we're taught to address these things. How do we handle them? How do we address these issues? Where is the standards for people who are trying this medication? If I'm going to talk on their side and say, this is almost as powerful as surgery. If it's almost as powerful as surgery, it has just as much power to the detriment as well. And so it is why I think it's so important that these medications, they can offer such an opportunity for people. It can be a gateway for people who finally seek some form of treatment. And maybe that's their long-term treatment. Maybe it leads to them of maybe making lifestyle changes eventually after the medicine and combining it. Maybe they ultimately have surgery. There's so many positives, but I'm fearful that we're going to hear more about the negatives because it's being applied so poorly in certain situations.
Yeah.
How in the world did all of a sudden 50% of the plastic surgeons in the world develop a heartfelt need to care for the obese population? Why is that? Why is it? Let's be honest. It's become transactional. I have friends who are plastic surgeons who've hired nurse practitioners to run their program, and they do a great job. It's not an all-comer. There's bad players in every category, including mine. But my point is, why is that?
Yeah.
We know why it is. Why do we now have to pay a monthly fee to see an online provider so we can get access to a medication when they have insurance? Because guess what? Your insurance will typically pay for an office visit if you come see me, even if you don't cover GLP-1 medications, because you have a diagnosis of hypertension. And I can still give you nutritional advice. I can still set you up with a dietitian. So we just have to be really careful. And I think the patient has to take control of their care and keep these things in perspective when they start seeking out, where am I going to be treated for this?
Yeah. And the other thing, and I had thought about this and wrote about it, is before surgery, and it's an insurance requirement. So it may be a difference in insurance, right? When you have any type of weight loss surgery, I would say maybe if you're not self-pay, right? And certainly not if you go out of the country, you have to have a psychological evaluation.
Absolutely.
That's what's not happening.
Why do we do that? To identify eating disorders, to identify traumas that need to be addressed, to identify psychological issues, whether it be bipolar or things like that, that maybe certain ways we have to manage all this stuff. I always tell people, don't be scared of it. It's not there to disqualify you. It's there to give us great insight on how to support you throughout your journey. Again, if somebody wants to argue that these things are verging on the power of surgery, which they're not there yet, and I think it's going to be a while, but if they're verging on that, anything that has the power for good has the equal powerful evil if it's misused.
Yeah.
And I think it's really important that we remember that. So if the government's not requiring it, if your provider's not requiring it, you out there, who are you getting this from? And here's what I would say. Ask yourself one question. Did you choose a provider that provided the least number of roadblocks to getting what you wanted, which is the prescription? And why is that?
Yeah.
And if you are looking for the least number of roadblocks, are you telling yourself, maybe I'm not ready to do some of the hard stuff?
Yeah.
And that's okay.
Yeah.
Because if you're admitting that, then find someone who will help you do the hard stuff and give you the best. And you're probably going to be more successful long term.
I have one more thought that is a little bit more social. One of the things that I've been seeing, it's interesting, not so much inside of bariatrics, but I've now seen different groups and resources pop up for GLP-1s separately. And there is this notion of, oh, I'm not bariatric. I'm just on a GLP-1. You're like, it's like inferior. And I know I have been starting to say, wait a minute, we're all healing the same thing here. We're all working on the same cause. But I've noticed that there's this, I don't know if you've seen that. Have you seen that? This social, almost like pitting resources against one another instead of being more all-inclusive to understand we're all trying to reach the same results of healing medical disease and longevity, health, wellness, all of those things, and achieving fat loss. Have you seen that at all? Or is that something?
Oh, I think, are you referring to the kind of the battle of modalities? Yeah. Oh, absolutely. Absolutely. And
a pain perspective, it's not professionals that are doing this. It's almost
the way that they chose, and it was better than the others.
Exactly.
Yeah. Oh, absolutely. Absolutely. The same people that wanted it are isolating their group. Yeah, I think it's human nature. It's unfortunate, but it's human nature. I always warn people. I was taught at an early age that if you have to point out other people's deficiencies, glorify the things that you feel like you do well, you're exposing your holes. You're exposing your weaknesses. If I, as a surgeon, have to talk about the surgeon down at the next county and talk about how bad they are to get people to pick me, I'm exposing that I'm not that great.
Yeah.
If I talk about what I do, and if I'm doing it well, I'm going to be good.
Yeah.
And I think with patients, it's almost like they feel they're part of a fraternity. I'm a GLP-1 patient. I'm a surgery patient. I did it all by myself patient with no help. When our ultimate goal should be, I did it.
Right.
We're all different. Our disease is all different. Some people need a lot of stuff to help. Some people need a little stuff to help. But for some reason, they've collectively got into these groups where it's the GLP-1 patients against the surgery patients, or it's the surgery patients against the GLP-1 patients until they decide that they want to add a GLP-1, and then now they're part of both groups. And we're all just trying to resolve obesity. And I would love to see those groups come together. I'm very careful because I think as a surgeon, I've done this a long time. I've treated a disease a long time. Just because surgery was the way that I treated it doesn't mean that I don't get it. I don't know everything. I'll be the first to tell you, but I've seen a lot of things come and go. And so I think that no one's wanting to talk about the warnings. I know there's people out there that says, as a surgeon, you feel threatened about this and that's why you're talking about it. No, it's not. It's really not. I've been very blessed. My surgical volume has continued to rise in the face of GLP-1s. That's not the case in a lot of practices. But if somebody's not going to talk about it, I'm going to talk about it. And I think that we should be doing whatever we can to just encourage people to seek out treatment to resolve their obesity. And more importantly, get to the root problem of how we keep the obesity gone for good.
And I think that kind of sums up everything, because not only when you think of, again, metabolic disease and all of the different ways that you can heal it, it takes a village. It takes all of the modalities to come together. And I think that can be helpful too, to have people share their story around what is coming up. And I'm specifically talking about people who have had weight loss surgery, who are experiencing, again, food noise. But what is that? Tell me more, explain it, give me more insight. And I think that has helped me understand it. It was even a shock to me when it first came out, not the GLP-1s. That was not a shock, but the
food noise, a term that was almost non-existent, and everybody's familiar with it now. And don't think Big Pharma invented it. I think Big Pharma is writing. They are marketing it. My goodness, Weight Watchers, when they decided to prescribe GLP-1 medications, they ran an ad campaign and a social media campaign where they rented out a house on the mountains of Southern California, and they called it the Quiet House. They did multiple social media bits from that. If people don't think these are using this, and I mean, to encourage the medications, you're crazy. You're missing it. You're completely blind. I'm not being insensitive to it. I'm just saying that I have 19 years, I have not seen people who, if they overeat whole foods, get into the same predicament as people who overeat non-whole. I'm not saying there's not people who can be overweight from eating too much steak and chicken and fish and broccoli and fruit. But what I am saying is the likelihood, if we rewind the clock 40-some years ago before ultra-processed foods came to play, look at our obesity rates. That's not a coincidence. There were definitely people that loved steak. I could crush a ribeye, and if it's really good, I would want more. I just don't have a lot of room, but I fill up much quicker on that than a lot of other stuff that are made differently and engineered to be made in a way that I'm supposed to want more of. And so the majority of this noise is not coming from a broad category. It's coming from a subcategory I don't consider food. And we've got to talk about it. We have to be aware of it. And unfortunately, many of those foods are foods that are geared towards people who are trying to lose weight. It's as simple as that.
Yeah. Okay.
And that's their marketing group. That is their research that they've done, and that is the clientele that they're going after.
It is. And that's where, when you were talking about maintenance, right? So when people are looking towards maintenance, like weight loss, like you said, is, you might have not said easy, but it's like you can get there, but then are you staying there? What are the changes to stay there? So what's one major change that you believe needs to happen in healthcare, maybe a loaded question, to support long-term outcomes for patients with obesity?
For obesity, we have to figure out how to get to the root of the problem with the food system. I 1000% believe that.
Yeah.
I hope it makes me have to find a new career in 15, 20 years, and I'll be totally fine with that. I'll be okay. I'll find something else. That's the only chance.
Yeah.
We have to have options to treat obesity. We have to get to the root of the problem. When the conversations come up about the government, say Medicare, covering things like GLP-1s, I did an interview with Newsweek, and I said, and on my opinion on that, I said, I'd love to see that, and here's the problem. If we do not get to the root problem of the food system, we are perpetuating a chronic disease that Big Pharma will benefit from for the rest of their lives. Big Food, Big Pharma, 50 to 60% of those hands cross the aisles, and they cross the pocketbooks. And so if we create a medication for a chronic disease, and if we allow the chronic disease, so here's the best example I can give you to close this out. If 40 years ago, I think it's close to 40, if 40 years ago, we didn't blow up big tobacco, we didn't have the whistleblowers, we didn't get the attorney generals involved, we didn't do the class action lawsuits, and we just said, we're going to spend all those financial resources in developing the best surgical and chemotherapy treatments for lung cancer. We may change survivability slightly. Our incidence of lung cancer would have never gone down. If we're not careful, that's exactly what we're doing. We are saying, keep creating a chronic disease because it plays a major role, but we'll just continue to have businesses that benefit from treating a chronic disease that you need it for the rest of your life. We have to blow up big food, just like we blew up Big Pharma. There's still going to be obesity. There's still lung cancer. There's still people. Do I think people should lose the choice to eat Cheetos? Heck no. You should be able to eat whatever you want, but you should be very clear in understanding what's in those foods. We sure as heck shouldn't have them on snack programs where it's our obligation to provide nutrition for the less fortunate, and we're giving them 60% of the list of things on that list have no nutritional value whatsoever. We're creating a sicker group of people, and all we're doing is perpetuating the problem. And if I'm Big Pharma, I'm like, this is a base. We got to blow up the problem.
Yeah.
And if we can reduce the incidence, and then for those that still suffer from the disease also have a treatment, game over. We're going to win.
Yeah.
But until we do that, I don't think we're going to change anything. We'll make dents. We'll make small little dents. But for those people that have it, despite blowing up big food, we have to treat it here and here. Whether it's a medicine, whether it's surgery, if the disease can respond similarly to medicine and surgery, the treatment support has to be the same too.
Yeah. I think it's also about empowering people to make empowered choices for who they want to be as a healthy individual. And again, giving them the unity to do that.
Yeah.
Thank you.
Yeah, you're welcome.
It's been great. I love your insights. I could talk to you for forever, but I know we have other things to do.
But no, it's been great talking to you, and we'll talk again soon.
Thank you for your time. I appreciate it.
All right. We'll see you.
That wraps up another fantastic episode of the Bariatric Mindset Podcast. Thanks again for listening, and I am so excited to see you in the next episode. Be sure to check the show notes for our guests' information and where you can find out more about bariatric mindset resources. See you next time.